Welcome back everyone. Now we have clinical session breast DIBH and IMRT by Dr. Santam. We welcome you, sir.
So, good afternoon. This is the post-lunch session. So, we will start off with a poll first of all. And let me go back. Okay, so if you will have the join code 42933178. Sorry, what? Okay, so go to menti.com and use the join code 42933178. Okay, people are still trickling in. Yeah, interesting. So the vast majority of you seem to be using moderate hypofractionation and very few are using conventional fractionation. So that means that we are looking at nearly same dose constraints. So that would be useful. This is a question regarding what type of respiratory position management or motion management technology is available with you. If you do not have any one, just select none. You can select more than one option. Yeah, so we have nearly a sort of a similar split between Electa and variant solutions that basically mimics the way installations are in the country. Interestingly, quite a significant proportion do not have any position management system at all. So the third question is, do you use DIVH in patients with breast cancer? The options can be all breast, selected breast, none, and do not have the equipment if you don't have the equipment. Okay, so I presume that most of you who have access to DIVH are using it for all left breast cancer, which is excellent, and quite a few are having some case selection criteria, which we will get to when we go for the discussion. Now, if you're not using DIVH, what is the factors which you think are the most important which prevents you from implementing DIVH in all patients? more or less stable now. We are looking at patient burden followed by financial and quality assurance issues being quite important. And interestingly, a significant proportion seem to be not convinced about the benefit also, which is quite interesting. So if you are doing DIBH, who does the counseling for the DIBH? Again, you can choose multiple options. Okay, so mostly oncologists and radiographer led. Thank you. So let's go on to the presentations, and the way we have structured this session is I will first give a brief about DIBH, followed by how we do it in Tata Medical Center, following which I will invite Dr. Jyotirup Goswami and Dr. Pritanjali Singh, who have experience with ABC, because we don't have ABC in our center. So put this up. So DIBH, for those of you who are aware of it, is basically a form of gating, right? What are you doing? You are essentially relying on the patient's ability to hold the respiration, which serves as the gate, nothing more, and basically called deep inspiration because you are asking the patient to hold in breath. And these are various methods which are available for use, and we have seen that RPM and ABC are most commonly used in this place. So why do you need it? Because if you are doing a simple conventional planning, what happens is that usually for left breast cancers, you end up irradiating a significant portion of the heart. And what is important over here is that this portion which is getting irradiated is probably the most important in terms of predicting future coronary events. This is the apex of the left heart. Now, one of the traditional methods is to use shielding, which is being illustrated in this second image. Now, what is the issue? The issue is if you do a simple shielding using tangents, what happens is you end up shielding a portion of the breast CTV on both the sides, which can result in marginal misses. So why do you do DIBH? Basically to spare the heart and spare the substructures of the heart, and we will come to both of these situations in this image. So what actually happens during DIBH is not that the heart sort of moves down. What happens more is the heart becomes a little bit more tubular in shape, sort of rotates inwards, and is basically pulled down by the diaphragm, as a result of which it moves down from the treatment field. Now what happens also as a result is there is a vessel which is located right over here, which is known as the left antedescending artery. Now this left antedescending artery is the vessel which supplies the vast majority of the blood supply to the left ventricle. And we know that atherosclerotic events to this left antedescending artery is associated with a higher risk of developing significant myocardial infarction and myocardial infarction related morbidity. So when you are doing DIBH, you are not only pulling the heart away from the chest wall or the high zone of irradiation, but you are also effectively reducing the dose to your left antedescending artery, which is very important. You also end up reducing the dose to the left ventricle. So that's another important cardiac substructure to which you end up reducing the dose. And do these cardiac doses matter? This, I think, has been shown to you down for the third time in this course. And the reason why this is shown is because this is such an important paper. Now what this paper showed was that with each gray increase in the heart dose, or rather the mean heart dose, they showed that there was nearly a 7.4% increase in the risk of developing a major coronary event. Now, if you go to the supplement of this paper, they actually have shown examples of how this actually affects the patient who is sitting in front of you, because this risk increase is not completely same for all patients. It depends also on the baseline risk of developing a cardiac event. So therefore, a patient who has a prior history of a cardiac disease or risk factors which predispose them to having major coronary events have a much higher risk than this 7.4%. This is very important to remember. What you are seeing in this 7.4% is the average. It is also known, and in their paper they had actually shown this, that doses to left antidescending artery were associated with a nearly similar linear response. The only reason why they chose not to highlight it in that paper was probably because of the R-square value of that linear regression which they received, which to me is a little surprising decision. So I will be talking primarily about RPM based DIBH implementation, as we have been doing it in our center. And in our center, the patients are basically selected on very simple criteria. That is, they should be able to hold their breath for 15 to 20 seconds. We really do not have a free breathing hard dose threshold to select the patients. This is not an uncommon selection criteria which people have. So practically all our left breast cancers undergo treatment with DIBH, except for probably a very minor population where there is a patient is having significant restrictive lung disease, or very elderly patients, or those who are unable to comply with the instructions. We have an initial round of pre-treatment counseling led by the physicians when we counsel the patients initially, but the majority of the counseling is actually done by trained radiographers. And these radiographers will show them using a video process where they will show them the benefits of doing DIBH versus not. We have found that patients are usually very compliant with the process when you explain to them. We have 3 practice sessions usually, and these practice sessions are spaced out about 1 or 2 days apart, wherein we ask these patients to breathe in and breathe out, practice the breathe hold pattern, and we also teach them how to follow the instructions. Now, this is important because in our country, language is often an issue, and one of the very common things in India is that the dialect actually changes every 10 kilometers. So this is very interesting. So the practice sessions not only help people to understand their breathing pattern, but also understand how the instructions will be provided during the treatment, which is important. Now, we used to have a screen which sadly has become defunct. So we have been doing without the screen for quite a few years, but for those of you who do have access to goggles and screens, it actually helps with the process. The final scan is taken once we have a demonstrated threshold which is stable and reproducible. And this is how we decide. We sort of keep these threshold limits to within -2 mm to +3 mm of the trace. Typically 15 to 20 seconds breath hold is sufficient for most of the tangential breast delivery that we do. And you know, RPM basically is a system which relies on detection of infrared reflected markers. So these are markers which reflect infrared rays. You have an infrared camera which is attached to the CT couch, which sort of tracks the movement and motion of this. These are some of the traces that we have seen in our patient population. This is all by Anurupa, who is our physicist, who has actually led these efforts over the past 6 or 7 years. And you can see that with the trial, there is definitely an improvement in the quality of the breath hold. Not only does their ability to, maintain a threshold improves, but also their ability to maintain it for a longer period of time improves. What I feel happens is essentially they get a sort of a muscle memory. They know where the chest wall should move up to and when it should move down. That I think is the most important thing, rather than the amount of breath hold that we have to do. So this has been our workflow with RPM. The execution process is quite simple. You have an RPM camera on the machine, which actually allows you to see the movement, reproduce this motion, and essentially deliver. We take a free breathing and a breath hold scan for each patient, but our target volume delineation and our planning is done on the breath hold scan mostly. The free breathing scan is sort of kept as a backup. For a very rare circumstance, if our RPM breaks down and is not available, and we have to continue the treatment using without RPM. So with that, I would now like to invite Dr. Jyotirup Goswami, who actually has experience in working with ABC, so that we can learn how ABC systems work.
Thanks very much, Shantam. So we're going to look at one of the 2 major techniques of breath hold, and this is something that it was my privilege to work extensively with at my previous center, with which I'm still associated. I also now have access to voluntary DIBH and also service guided radiotherapy, but all my foundation was based on ABCD-IBH. So we don't want to go into all these things about lung motion because that's been covered. So the idea is that the patient is able to produce an accurate breath hold to a known volume, and they observe their own respiratory information. As Shantam said, there is a patient display monitor which is available at the treatment couch as well as at the CT simulation couch, so the patient is always synced with what we want. As he said, patient coaching is vital, and this is probably even more important for ABC-DIBH because it's not the most comfortable, and it does take some getting used to. And there is definitely a learning curve even for the departmental staff in terms of how much time they need to give to coaching the patient. Initially, I think our technologists would take roughly an hour, but I think they were able to then trim it down to about a 30-minute coaching session before the actual CT simulation. So that would be usually on the day of the planned simulation or maybe the day before. So as Shantam said, it is something that you do need to take a little bit more time for than with normal free breathing breast cancer simulations. And we're going to look at the apparatus. Before that, just a little caveat that we do believe in, which is not necessarily true all the time, and that is that the patient is breathing normally because their residual functional capacity is then a very stable point in the respiratory curve. And this is not necessarily true of every patient every day, but if the patient is coached and if they are comfortable and not tense, then normally they will be breathing fairly stable pattern. So we have the same apparatus, or at least a twinned apparatus at the CT simulator and at the treatment couch. The patient is positioned as always on a breastboard, and the only difference is that they are positioned so that they can see the patient display monitor. They hold a patient control switch in their hand, and they are positioned like this. So they have the breathing apparatus held in their mouth, which is connected to a tube, which is then connected to the spirometer. Now, the spirometer is obviously an unchanging part of the machine, which is why there has been an issue with this in post-COVID times. But the breathing tube is customized or is for each individual patient. Elekta ideally would like every session to be with one particular tube, but in practice we would have each patient use one tube throughout their treatment. The other bits and pieces that we need is the nose clip, which is to prevent any leakage of breath through the nose, so that the entire breathing is done via the mouth. And when the patient reaches a steady breathing cycle, they are then allowed to depress the control switch, which indicates that they're ready, and then they would take the breath. You can see a similar hit zone as we saw for the RPM system, and the idea is that as soon as the patient hits that the green zone with the blue tracing of their respiratory movement, that's when they know that they have reached where they need to. Now, obviously not every patient is able to hold their breath for equally long time or even to take an equally strong breath, but it's not necessarily true that even a shallow breather can't be taken up for DIBH. 20 seconds is a good cutoff for someone who will do well with DIBH, but even if it's for less, you can still get through a given fraction with multiple breath holds quite easily. And it's the same setup at the treatment table. So the idea is that once the software has been switched on, the patient breathes into the mouthpiece with the nose clip fitted. They press the patient control switch, which indicates that they're comfortable, and that should remain pressed for the whole course of treatment and not be released unless the patient is in need of assistance. The user observes the patient's breathing from outside the room, and once normal breathing is activated, system is activated. During the respiratory cycle, the patient takes a deep inspiration, which brings their volume curve into the threshold region, and this basically will continue till the treatment is delivered. Now, this used to be an entirely manual process several years ago, but now it's a gated automated process. So gated ABC is sort of like an amplitude gating, and compared to voluntary DIBH, I suppose this is a little bit more complex, a little bit more expensive, because you do need some extra apparatus. And in terms of the efficacy and reproducibility, I think it's roughly the same. I think there was a UK study which looked at comparing both techniques for a given population of patients, and they found that from the radiographer's point of view, the voluntary technique was probably a bit more comfortable and probably a little bit less time taking. In terms of the pros and cons of DIBH overall, I think Shantam has mentioned most of that there is that component of coaching, there is a component of cooperation, but it is incredibly empowering, because it's not often in the oncology journey that a patient gets to really control their own treatment. And even patients who are not necessarily very literate or very smart have been known to be very, very cooperative and very, very quick to understand the demands of the process. We've already looked at the clinical applications, so we won't look into those. And this is what DIBH can do. So you see the cardiac contour as a whole, and the LAD, that's the structure in red, move away from the chest wall or the breast with DIBH compared to free breathing. And that's on the SAD section, and that's on the DRR. And there has been some interest. So yeah, DIBH will reduce the mean heart dose. It reduces several other heart dose parameters, and as Shantam said, it also will generally reduce the max dose to the LAD. The lung dose is variable, and there has been some interest in selecting patients, which patients will do well with DIBH versus which patients don't. So some of the criteria used have been PTV volume, BMI, cardiac contact distance. But honestly, I think if you have DIBH, you would probably want to use it for all your left breast cancer patients, and that's what we have tended to do. Yeah, that's it. Thank you.
Thanks, Jyotirup. I would also invite Dr. Pritanjali to share her experience with ABC-based system, because I think it is important to also understand that while these technological systems exist, in low middle income countries like ours, they come with very unique challenges. So Dr. Pritanjali, if you can highlight the challenges.
So very good afternoon. I would at the outset like to say that ABC is a very robust system, and it is working very well in our department, except for minor setbacks when the spirometer gets dysfunctional. It is obviously a respiration synchronized technique, as has been highlighted by Dr. Jyotirup Goswami, and the indications that we are using in most are the left-sided breast cancers. We can do it on the right side, especially to remove the livers from the field, but we are not doing it. Especially we're doing it in the left-sided breast cancers, liver regions, especially for SBRT, when we are using maybe the metastatic, we're treating the metastasis, and thoracic tumors. We don't get to see many thoracic tumors because most of them present to us in a very advanced stage. And as an institutional protocol, we are advising pre-RT pulmonary function tests to all these patients. This was started in the beginning just to see what was the pulmonary function test of all these patients presenting to us for ABC. And we have not audited our results as yet, but we will soon be doing it to see whether the functional distress is not very much in these patients. Coaching, of course, is required, and we advise these patients and we give them education to these patients upfront, starting at the time when we're giving simulation dates. So they are advised at home also to be taking deep breaths and holding it for about 20 seconds. Then CECT simulation, both in free breath as well as ABC, is done, as Dr. Santam already had said, and that is obviously for the reason which was highlighted. Treatment planning, plan evaluation, and then DVH analysis is also done. And this is the ABC machine in our hospital. It has a cart, an ABC cart, of course a console, and of course a spirometer, which is attached to the patient through a mouthpiece, as you can see over here. And the conventional 3D plans, as you can see, involves the heart to a large extent, whereas when we are doing it with the ABC, you can see that the heart is out of the field in all aspects. The DVH also can be highlighted over here. This is the heart DVH planned with ABC, and this is without ABC. So this is the major part when it goes into the red, when the patient is basically holding the breath in the green region, then the treatment starts. And you can see over here. Treatment is starting. So we have to do it multiple times maybe till the treatment is over. And of course, again, what are the major challenges, as Dr. Santam asked me to throw our perspective as well as what are the challenges? Well, the QA of the spirometer has to be done, and that is usually done by the physicist with the balloon test or pressure test before every treatment of the patient. However, we have seen breakdowns of spirometer, and there are not many separate spirometers, so in between treatment gaps are there for patients. 2 or 3 days, it might turn up that we have to treat the patient otherwise with free breath holding technique, so we have to plan likewise. Counseling of the patients does take time, but however, we are able to do it. And when we are doing cone beam CT, then of course it is an issue because there's the imaging and the breath hold is not synchronized much, and sometimes the cone beam CT takes more. If the patient is not able to hold the breath for about more than 20 seconds or so, so the cone beam takes longer. So sometimes we do think that there's not much synchronization between the two. We are not able to treat patients and elderly patients with these, children as well as elderly patients with this technique. There's also potential risk of overdosing or underdosing patients in the field junctions, because when you are doing ABC and using ABC basically, and the lung is expanded, then the field junction might be a particular way, and the technologist that is coming in next might not find the proper match between the two. So basically the technologists also have a good learning curve before they take this treatment up. Patient setup and machine alignment measurements has to be seen. Patient compliance and comfort, fatigue is also of utmost importance, because many of these people, they have discomfort with the mouthpiece that they are using, and there's not much consistency in the breath hold. So because maybe once they become better with time, so for the first few fractions they might be holding it for 20 seconds, maybe and inhaling about tidal volume that is there, 1.2 or something. Later on it might be more or might be a little less. This, of course, there's a setup time for this. So we have delineated one of the linacs for ABC treatment so that the throughput of the other patients on the other machine is not hampered. And of course, as I said, coordination, synchronization of the imaging with breath hold is very important. So that is about it. Thank you.
So we also saw in the poll that there were quite a proportion of participants here who were not really convinced about the benefits of DIBH, right? And if I can have any feedback from any one of you before we go ahead with the next presentation, why do you think so? If anyone who has had answered that they were not convinced completely, it would be useful before we can go on to the next presentation.
There are a number of you who don't yet use DIBH. I presume that because you're still working in departments which don't have the equipment for DIBH. But is it something that you think should be, you know, a high priority for you, or is it relative to other conditions, other equipment, not that high priority? You know, can we have a show of hands of people who don't have DIBH? Nothing to feel bad about.
Yeah, we already had that poll, so
yeah,
quite a few.
Quite a few. And is it something that you would like to have? Is it, or do you think that even if you had it, you don't have the manpower or the resources to actually implement it? You'd like to have it, yeah.
Yeah, so I hope that by this presentation I would be able to convince you about the benefits of DIBH. And
Shantam, can I ask something? I
yeah.
mean, when we are doing DIBH, when we are implementing it, you're basically looking at the trace.
Yes.
And you think that everything is okay.
Yes.
Is there a way to verify?
Yes, what we do with our patients is we generally take a cine image to ensure that the cardiac solute does not come inside the bottle. That is something that we do.
Okay.
Yeah.
And but the cine image would entail some radiation dose? And
no, it's the MV cine image.
It's the MV cine.
Yeah,
okay.
so while the beam is on, essentially for the large field, it is easy. For the small subsegmental fields, the cardiac field anyway is not there, so it doesn't make a difference.
Right.
Yeah.
Right.
So, you know, means one of the key points with cardiac sparing is unfortunately that this is a late complication. So we tend not to see it, and even if we see it, we sort of may not regard it with the same degree of intensity as we would consider something like radiation proctitis or maybe pneumonitis and so on. So if we translate the risks into actual figures, okay, so let's understand, because this is a concept that is often challenging to several people. Suppose there are 1,000 women with breast cancer who are aged around 50 years who receive radiotherapy to the breast with a mean heart dose of around 2 gray. Now, why I picked up that figure of 2 gray? It's arbitrary. In our practice, this is the usual left heart dose, or it's actually lesser than this, but this is what we usually get. Now, in these 1,000 women, in an average Indian population, suppose about 1.3% develop a major cardiac event in 10 years. That means 13 women will have a major cardiac event, right? Simple mathematics. Now, if this 2 gray figure, if we just use that 7% relative increase, if they do not receive radiotherapy, 1.25% will develop, so that means 12.5. So basically, in order to prevent one cardiac event, you essentially end up treating 2,000 patients. So if you treat 2,000 patients, then you start to see, you know, the reduced cardiac dose. And you can understand what is the implication of this. To prove this in a randomized controlled trial setting is virtually impossible. It is also important to understand this is not a simple probability problem, but rather a conditional probability problem. Because what is the usual 10-year survival of breast cancer in India? Patients will develop a major cardiac event only if they survive, right? So this is what the usual figure is in USA, maybe a little bit more now with the advent of more, and this is a presentation which was allowed 7 years ago. So yeah. This is what the usual figure is for India. So about 10-15% lower 10-year overall survival. which means of these women, they will have even lesser chance of having death from myocardial infarction. So this is some of the tables just to show you what actually happens to the number needed to treat, right? Means how many number of women you need to treat to prevent one cardiac event with DIBH. If your 90% is your 10-year survival, your number needed to treat is around 2,222. But if your survival is only 60%, this number needed to treat increases to 3,033, which means you need to treat 3,000 patients in order to prevent one cardiac event. Okay, it's like this. However, the dosimetric gain that you gain out of DIBH is not disputed. Okay, means there are sufficient number of studies now to actually prove that DIBH will reduce the heart dose. The magnitude of reduction varies, typically around 50 to 60%. So we also did a study when we initially started implementing DIBH in our practice. This was in 2014, 2015, sometime like that. And at that point of time, what we did was we consecutively treated patients who were requiring breast radiotherapy. We did DIBH in them, and we treated them with free breath and before we implemented DIBH in a systematic manner. And we also found that if you do DIBH, you get a reduction in cardiac dose by about half. So these were our mean heart dose figures at that point of time. The question then comes is, what is the amount of resources that we spent in order to get there? So as I mentioned, this was a service development audit, and what we did was we took the time taken to implement each step of DIBH. You know, it's quite simple. Just go and record the time that everyone spends, compare it against the free breathing time, and then you can simply compute the person hours that is required. This is a simple multiplication. What we then did was we took the estimates of mortality reduction from Dr. Darby's paper, or from mean heart dose, right? Now, there is a caveat here. The caveat is that if you read Dr. Darby's paper, it mentions the risk of major cardiac event. It doesn't really mention the risk of death. So it is likely that that curve which you saw linearly would actually be lower, but the slope is not likely to change that much. So we considered the relative risk going to be the same. What was the expenditure? Again, very simple. You have the person hours that you spend extra. You multiply it by the salary. Of course, you got it in hours, and add in the capital expenditure, because that capital expenditure is going to be prorated over the equipment lifetime. And then what we did, and this was actually, interestingly, this came from a review. The suggestion actually came from a review. When we actually had submitted the paper initially, we had actually submitted up to this part. But then one of the suggestions from the reviewers came was, actually, can you calculate the cost effectiveness? And we thought initially, how can I? You know, there is no randomized control trial, how will I calculate? But then we thought again, and one of the interesting things that we came about is this very interesting resource called the Global Burden of Disease. This is a very large international study. India is also participating in this international study. And this interestingly gives you decile-wise risk of ischemic heart disease related mortality, as well as DALY. DALY is disability adjusted life years lost. So because of a disease, you will have a disability, and that will result in loss of life years. So the loss of DALY because of ischemic heart disease is also quantified. If you go to this GBD India website, it's actually free. You have these beautiful visualizations. We can actually compare how India fares with respect to the rest of the world. It's quite instructive with regards to ischemic heart disease. So these were our resource requirements. Now these vary from center to center, whether you're using RPM, whether you're using ABC, what is your coaching requirement, and so on. But what we found, on an average, if you wanted to reduce the heart dose by 1 gray, about 4 hours of person work would be required. It's simple, in broad terms. So what would be the impact? So if you look at our population of 50 patients, each of them had a different mean heart dose, right? They won't have the same mean heart dose with the free breathing and the breath hold. We computed the years of life lost because of ischemic heart disease with or without breath hold. That was quite easy. So what we found was years of life lost due to mortality from ischemic heart disease around 0.95 years per 100 patients treated. Okay, not much, but it's there. The amount of work that it needs to save this much is, however, only 681 person hours. And that is where the cost effectiveness comes in India from. Okay, so this is a spoiler. We could avoid 1.22 DALI per 100 patients. So in essence, it means that if I treat 100 patients, I will save 1 disability adjusted life year. That's what it means. And the total expenditure on salary, and this is very interesting, was only 0.18 times the annual per capita GDP. So you can understand how poorly we pay our manpower. So, what happens is, if you go by the WHO cost effectiveness guidelines, what they specify is, if your intervention results in a DALI preservation, 1 DALI preservation is, say, less than 3 times your annual per capita GDP, it is considered to be cost effective. That's what the usual WHO guidelines are for countries where there is absence of good quality adjusted life year data, like it is in India. So this is extremely cost effective, by the way. So it is counterintuitive to think that you are saving such few lives, but in the long run, this is very cost effective. So I hope this is a very short overview of the study that we did, and we concluded that, if you are doing conformal radiotherapy for breast, managing respiration is important, and in breast we can substantially reduce cardiac dose, and we can actually make a huge difference in terms of the potential mortality, and therefore probably it is quite cost effective in our scenario. So any questions till DIBH? Any comments before we go on to breast IMRT? Let me see how much time. Yeah, I'm on time. Yes, please.
Sir, in case of left side pendulous breast, which method you are using, DIBH or prone breastbone method?
That's a good question. We are using DIBH. We are not treating any patients with prone treatments as of yet. Partly because when our physicists will do the optimization, what they will typically do is that they will carefully outline all the folds, and they will be very careful in taking out all the areas of overdose. In fact, we will not accept anything more than 105% over there. Typically, we would want the dose and those folds to come down. It should be around 100% dose, not less than that. That's what we would want.
Thank you, sir.
Shantam, two
Yes.
situations where DIBH is of importance. One is when you have a bilateral breast cancer.
Yes.
I think many years ago people would probably think of maybe using DIBH for only the left, but I think it's important to use the same technique for both sides.
Yes.
And the other thing, which again we did not do much of years ago, which was IMN radiation.
Yes.
That's another situation where DIBH is potentially a very useful tool. That
Indeed. We actually, in our center, we haven't been able to use breath hold in IMN radiotherapy, specifically because of the fact that we cannot do breath hold on TOMO, in which most of our patients get treated. That's a very important problem which we are having, and there are now vendors which have proposed solutions to that. They are all quite expensive, however, unfortunately.
Do you plan on free breath also for justification?
Usually we did it at the beginning, now we no longer do that.
Okay, and in case of breakdown of RPM or some changes in
Yeah.
are you going for adaptive, or you are following the free breath plan or something like that?
See, for us actually we follow for breast cancer we follow the RCR, the category recommendations. So breast cancer comes under category 2, I believe, right? So for us, giving a break of 1 or 2 or 3 days, we really do not change the treatment plan just based on that. It's fine. If it is longer than that, then yes, we have changed the patient to a breath hold, free breathing plan, and planned accordingly with cardiac shielding if possible.
Just a comment, even for right-sided breast cancers, occasionally you can have a right coronary artery, which can
Yes.
be very unusually placed. So occasionally a breath hold might be useful for right-sided breast cancers. And the second point was for mastectomized patients, and we had done this study at our center, and we had seen that doing a breath hold for a mastectomized patients would offer a greater degree of reduction as compared to
Yeah,
breast
particularly
conservation.
because for mastectomy what happens interestingly, I believe our lower volumes are always larger than it is for a breast conservation, because in mastectomy we are unable to see the contour of the breast, so our target volume sort of comes straight when ideally it should curve in.
Santam, I was just wanting to ask that for non-coplanar beams that you have planned for any patient, what is your guide for DIBH in your institute?
So
Because
all
we
our
can
breast
only-
patients are planned using non-coplanar technique. So we use a couch collimator kick technique, and what we typically do is that in our old Novalis machine, for the SCF fields, because once the couch moves away, it is not possible to use the RPM anymore for
Yeah,
getting the
that's
breath.
right.
So we used a camera which was zoomed into the SCF field to keep a track of. So the SCF field would be delivered manually under visual guidance. In TrueBeam, interestingly, because of the limitations of the laser guard and the size of the rotation, it is not possible to keep the light field on during treatment. So we are now using laser-based localization to ensure the match.
Okay. Thank you.
So after discussion of the RPM and ABC based technique of DIBS, so at present moment of time, how do you rank one over other?
I don't think there is any ranking possible in the two. It is trade-offs, right? An RPM based system is non-invasive, does not require you to purchase consumables, but I believe the cost-wise initial outlay will be more, capital investment-wise. As far as the utility of the technique, I don't see any reason why you would believe that RPM would be substantially superior to ABC in terms of clinical outcomes. Whatever you have, please use that. I think that is what my message would be.
So for the patients of left breast cancer, so at your center you use DIBH with IMRTs.
For left breast cancer, we use IMRT for all breast, but
Yes,
our IMRT is not rotational or multi-field IMRT. Our IMRT is field-in-field IMRT. So yeah, we use IMRT, but it is always tangential field-in-field based IMRT.
So I think that treatment time will be lesser, sir.
Not much. See, it is the treatment time is not really a consideration for DIBH. You have to understand this, that you basically want to have a sufficiently long breath hold time that your machine can deliver a certain proportion of the dose. If the patient needs another breath hold, they take another breath hold. That just increases the time on the couch, nothing more.
So, but for a rotational IMRT, it becomes practically nearly impossible to do. Sir, because we face-
Rotational IMRT, it is possible, but I would imagine you should have some form of a gated delivery system available which will hold the rotation with the breath hold. So you should not be doing it without having gated delivery. That's my viewpoint.
For in that case, actually, we are using the thermoplastic cast and IMRT. So it is
The
equivalent.
thermoplastic cast is basically used as a proprioceptive technique to make the patient understand that they have to touch up to that, right? Is that so?
No, sir. Free breathing.
Oh,
Cast is used as an immobilization device.
so means we don't use cast, but technically speaking, your cast is not going to give you the benefit of doing a breath hold.
So, but we are able to do IMRT plan in that, and so the dose, the hard dose.
It may be possible for you to see if it is possible to plan these patients with tangential field in field. I don't know what your technical limitations are,
Yes.
which may actually give you better dosimetry as compared to rotational IMRT.
Yes. And one question to Pritanjali ma'am. Ma'am, regarding the study that is ongoing here, the pre-treatment PFT is being done. So my question is, what is the hypothesis about that?
Not exactly a study that we're doing, but we were very skeptical when we were starting on with ABC. So we just wanted to know that our patients had correct PFT levels, and we have continued that. So we have to audit our retrospective. We have to audit, and we have to see are the levels okay or not. The pulmonologists, they tell us whether there is any volume that is restrictive or anything. So then, of course, we do we do go on with, if the patient is able to undergo breath hold, then we do give them the treatment. But we have those PFTs with us, so we will have to evaluate first. Okay?
Actually, I had done my thesis on DIBH. So, like ma'am had told, we got a better dosimetry for MRM patient as compared to BCS. And also, this PFT I had also collected, and this kept with me, and I had in no way I was able to correlate with any of the data points. And one patient had interstitial lung disease, and she was unable to hold breath also. Yes.
Thank you.
Thank you.
So we will now move on to the second part of this clinical session, which was on breast IMRT. And before that, let me reiterate the benefit of adjuvant breast cancer radiotherapy as per this, the famous plots of the EBCG meta-analysis. What I would like to highlight to all of you is adjuvant breast cancer radiotherapy improves outcomes in all subgroups. Okay, there isn't any subgroup where it doesn't improve outcomes. If you're talking about local recurrence, there is absolutely zero subgroup where it does not improve outcomes. The questionable benefit is in terms of overall survival, but I believe there is still a sort of an element of patient-specific decision-making or patient-shared decision-making involved whenever you are treating a patient of breast conservation with a very low risk where you want to omit radiotherapy. So, to brush up the principles of conventional planning, because these will be important before you are implementing IMRT in your practice, these are the key principles which you should know. The first thing is that if you are opting for breast cancer radiotherapy planning on a conventional technique, tangential irradiation is probably the best way to go about it. You should select your medial and lateral entry points properly. The posterior edges of the beam should be properly matched because these avoid divergence into the contralateral breast and the lung. And I think I don't need to tell you why that is important, because you are treating adjuvantly, you are not treating definitively. And the vast majority of these women, even in our country, where the survival rate is 70%, would be long-term survivors. They would be cured of this disease, they would go on to survive. You really want to follow the ALARA principles for their OARs. Keep the central lung distance between 1 to 2 centimeters, and if you are using regional nodal fields in any of the patient, ensure they are properly matched. So with this, why use IMRT at all in breast cancer? For 3 specific reasons: to homogenize the dose, which has the greatest amount of evidence, integrated boost, and partial breast irradiation. And we will briefly look at all of these situations. So interestingly, this is the earliest breast cancer IMRT trial. Okay, this was published by Donovan et al. In 2007, where they showed that if you use simple field-in-field IMRT, by the way, this is not rotational IMRT, this is in multi-field IMRT, this is simple tangents with dose homogenization using field segments, you reduce the change in breast appearance change by about 1.7 times. There was significantly fewer clinical induration, and this study from Mukesh, which was done in Cambridge, is one of the largest IMRT trials that has been published till date, where they conclusively demonstrated that using intensity modulated radiotherapy, again field-in-field intensity modulated radiotherapy, improved nearly all acute and late toxicity endpoints. Simultaneous integrated boost is another application, and this is something that we have been doing in our center for the past 3 or 4 years. We have had a very intensive commissioning process for this, and if you see, our approach for simultaneous integrated boost is again based on the ALARA principles. So what we do is that we use 2 tangents as before, and we use very small arcs, butterfly arcs, which are sort of offset by around 10 to 15 degrees from the central axis of the main tangents, and the dose in the field-in-field technique is homogenized such that the dose inside the boost volume does not spill out too much. Now this is one of the earlier examples of our patients where there is still a substantial spill out, But using this technique, what we could achieve was very low dose to the contralateral breast, lung, and the heart. And Import High, as you are all aware now, is one of the largest randomized controlled trials, again performed in the space of breast cancer, which has demonstrated that using an SIB approach is feasible. Now, the dose escalation didn't translate into a significantly improved outcomes, but they had 2 dose levels, and the SIB dose level of 48 gray was not anyways inferior to your usual sequential boost approach. There are other sequential simultaneous integrated boost randomized controlled trials which are also available now. Coming to partial breast irradiation, this was the first trial sort of APBI IMRT Florence trial, which demonstrated again that using IMRT resulted in improved dosimetry, and then that was associated with better cosmetic outcomes with similar disease controls. What is important to understand that this partial breast irradiation trial employed fixed field IMRT, 4 or 5 coplanar fields. So this would be what traditionally you would mean by, inverse planned IMRT, that kind of thing. On the other hand, the Import Low trial, which was subsequently published, again is one of the largest APBI trial, and although it is not accelerated by any definition, it is partial. And what they demonstrated that using IMRT, again field-in-field IMRT, to deliver partial breast irradiation resulted in better outcomes in terms of toxicity, which we will come to here. So you can see that the breast appearance change is again substantially reduced. You do have improvement in terms of the breast feeling harder and smaller. So interestingly, in breast, there is actual evidence that your dose homogeneity matters. There is also evidence that the volume of irradiation matters. So this is one of the rare sites where you have evidence of both of these things being important. From our side, we have been running a randomized controlled trial called HIPOT, which we are looking at a moderately fractionated dose of 40 in 15 versus 26 in 5. And what we have been doing is we have been using simultaneous integrated boost to deliver the boost for these patients. This is just to highlight that these are the kinds of constraints that we follow in this trial. They have been derived from the import experience. And when we actually did the commissioning of this trial in multiple centers, we realized that maintaining these constraints is not an easy affair. Means there was quite a bit of back and forth going back from very basics, like where do you make sure that the posterior edges are properly aligned, how much of the lung you are taking inside the field, where you are keeping the edges of the tangents and so on, which was extremely important. And means in our recent experience, one of the centers, none of the plans actually met any of the mandatory constraints. So this is important. So for those of you who are practicing rotational IMRT, it is actually very important to look at the low dose bath. This is our adherence to the constraints. This was presented in ESTRO 2024, and we demonstrated that the constraints that we had proposed as a part of this trial could be met in our patient population. So this is an analysis of around 1,000 patients, and this was done without compromising the lung doses. So the take home from this small talk is basically breast IMRT actually has a wealth of evidence. Inverse plan IMRT is typically not necessary unless you are planning for complex regional nodal irradiation. Adjuvant breast radiotherapy should be planned carefully if you are using IMRT, and you should keep in mind the contralateral breast and lung doses. So let's go back to a short poll because we do have time. Yeah, we have 10 minutes. Yeah, so now you can scan this QR code. I forgot to put up this instruction slide in the previous one. Or you can just put in 125385661. Right, I haven't given any of you guys an exercise or an homework to do, so we'll do a small homework inside, okay? Rather classwork. Right, so let me quickly understand what is the kind of machines you have, right? So this is quite interesting and quite heartening actually, you know. I remember that in my second national conference which I attended, one of the talks was on the benefits of radiotherapy using telecobalt and linear accelerator, and it was sort of put up by a very senior person that for breast cancer you don't need linear accelerators. I am very happy that we have gone out of that mindset and now we are treating patients on linear accelerators at least. And there are about 11 people who have access to a ring entry, which is also quite interesting. So what proportion of your patients are planned by each of these planning techniques? You know, like 0 to 100, if you are planning a proportion of patients with clinical markup, that's fine. I just want to know. Okay, so around, there is a small proportion who do clinical markup even now, which is quite interesting. And when we are talking about advanced technologies, we still have resource limitations which prevent us from doing simple basic CT simulation for all our breast cancer patients, which is quite interesting. So I want to know from you what is the most common technique that you use for irradiation for whole breast. Mind you, this is not regional nodes, just post BCS only the entire breast is being treated, not regional nodes.
More than one option?
Yes, if you want to. Oh, it's not there? Then just choose the most common option. Oh, I have mentioned the most common technique actually. Right, so a substantial proportion actually do IMRT and VMAT interestingly. That's quite interesting. Okay. So this is the next question. What is the highest isodose that you accept in your breast plans? Okay, typical breast, you know, what is the highest isodose you will accept as a point dose? So roughly 20% will actually accept an overdose exceeding 107%, which is quite interesting. There would be a very interesting case scenario of doing a cross tabs between this and the previous question. I would like to see what is the response for those who use tangents versus those who require VMAT. Okay, we typically would want to make sure that the doses are less than 105. That's in our practice. We keep 105 as a cutoff actually. How are breast fields matched to regional nodal fields in your practice? Right. So the vast majority are using a single isocenter technique. I can see there are a few who are using a collimator couch rotation technique. That's interesting. Okay, this is an easy one. Which was the first randomized control trial was reported for which cancer site, do you think? Among these choices. Okay, so the answer is actually interestingly breast cancer, not any of the other threes. But what was the first site? It was nasopharyngeal cancer. Okay. Which of the following guidelines do you use for target volume delineation, since significant majority of you are actually doing IMRT? Okay. Yeah, more or less a split. You can choose no target delineation if you are not delineating the target, which is fine. So the vast majority of you are using the Aroi-Estrp guidelines, right? Excellent. Since all of you are using Aroi-Estrp guidelines, so can you answer this question? Where is the subclavian vein located with respect to the subclavian artery? Cranial means it is located above, caudal means it is located below, right? Okay. Okay, very interesting. Actually, the correct answer is the third one, caudal and in front. So, Indranilda, I think next time we must do a contouring exercise for breast. Okay, which of the following are the caudal limits for IM and nodal CTV? Okay, most of them got it right. It is the fourth rib because we treat the first three intercostal spaces. Okay, so now there is a breast CT scan that would appear in your mobile. I want you to point out where you would want to keep the lateral extent of your breast CTV. Just click on that point. We don't have a system of prices here, right? Huh? What? Funding, yes, of course. Oh my God. All over the place. I guess some of it has to do with the fact that you are tapping on your mobile. But few of you are actually going to the correct location. Can anyone tell what is that correct location? Name of the location? Yes. Very good, very good. In this, I would want you to identify the medial landmark. It is seen actually. Okay. Yes, there is one person I can see who has put it. Most of you are keeping on to the medial edge of the sternum, right? That's not correct, by the way. You go back to the Aroi-Estrp guidelines and read it. It is the perforating branch of the medial mammary. Okay, so there is one person who has highlighted that point. Good. And means I guess these are all like probably just probably showing the caudal border more than the medial border, right? Okay. Okay, outline the position of the internal mammary vessels in this image. Good. We do have good correspondence in this. There should be less error. Okay. So that's what from my side. I do think we have 5-10 minutes for questions. Yes, we have 5-10 minutes for questions. Correct.
Sir, we do not have any kind of motion management right now. So we are doing half-arc VMAT for breast cancer patient. So, sir, is it possible to use any kind of, ABC or DIBH, whatever, in case of VMAT, half-arc VMAT or what?
Once more, when you are using VMAT, what you have to understand that unless you are having a robust way of stopping your arc and starting it again, it is very difficult to do.
Okay.
Because it is quite possible that your patient may not be able to hold the breath for the duration of the arc,
No, it's
right?
not possible.
But it is entirely possible to treat without an arc.
Okay, and sir, in your cases, I mean in TMC, how many breath holds are required to complete, I mean tangential fields, I mean the breast treatment?
Usually, so if it is say breast only, probably 3 or 4.
Can I add, Shantam? I will cover this in next session of how to break arcs for planning when doing breath hold. I will cover in next lecture.
Yeah.
Anybody else? Okay, so that's good. Thank you.
Thank you.
So we'll take a short break now and be back for the final session.
Today's last clinical session is on liver SBRT by Dr. Supriya Chopra. Over to you, ma'am.
So now I have to open Mentimeter directly. Okay, so good afternoon, and I hope I can keep you entertained and awake for some more time. We'll speak about, in the next 1 hour, 20 minutes, about SBRT for liver metastasis. And I think at the outset, I would like to mention that please join menti.com, because there will be questions to keep you awake in between. And please take note of this code. Okay. Is everyone done? We can move to the next slide. So what we are going to do is speak about oligometastasis of liver, and we did not cover intrahepatic primary tumors because managing them and treating them requires a totally different set of nuances, and considerations are very different. But I listed here indications where liver SBRT can be used apart from oligometastasis. Whatever I am going to speak in next sessions should not be directly applied to hepatocellular cancers, especially if they are large and if they come in the background of deteriorated liver function of child B and C-score. So first question for all of you, can you please start answering this if you practice liver SBRT? Shantam, you had many more replies and quickly, right? Maybe people are still out. So we can see actually far majority of audience are practicing, and can I just please have show of hands so that we can also be interactive in between amongst the people who said yes, who are doing? Can we just have a raise of hands here? Okay, excellent. So overall, much has been said, and yesterday Tejpal also mentioned that people seem to be more comfortable with certain tumor site SBRT as compared to others. We talk often about liver metastasis, but you see if overall registries, liver metastasis are only 5% of synchronous liver metastasis. In addition to this, there will be patients who will develop metastasis during the course of their illness or once they are cured. But really speaking, it is a small proportion of metastasis overall for any metastasis-directed treatment. And surgical resection and RFA, actually, they remain the gold standard because of also some better quality evidence that is available for them. However, very few patients undergo surgery, and when the metastases are slightly large, the RFA is not equally effective, which makes SBRT a very lucrative treatment option. And if you look into the utilization of liver SBRT, it's around 6.2%. So it very much matches the incidence of liver metastasis overall. Before we go ahead, I think it's very important to remember liver anatomy, because when we are talking in multidisciplinary teams to decide about metastasis-directed treatment, surgeons and intervention radiologists would always speak in terms of liver segments. And I put this small cartoon here of your right fist, how you remember what the liver segments are. And really speaking, if you move apart from the caudate lobe, which is 1, it's really a clockwise distribution. So when I'm also going through cases, remember segment 5 and 6 are below the portal vein. So imagine these knuckles are the mid segment of the liver where portal vein goes. And then above is 7 and 8, below is 5 and 6. And all this is based on vascular anatomy. Now this is very important because all the surgical resections are with vascular anatomy, and principles of liver SBRT and HCC, especially for HCC, they are evolved over normal liver volume. But we can also be more brave if we look into surgical anatomy like surgeons do, and also think of liver regeneration during SBRT and go in a more aggressive way. So this is again a question for all of you. Do you think all segments are equal and liver metastases are distributed equally? Or do you have different incidence of liver metastasis in segments? I'm waiting for someone to say this is a stupid question. No one is selecting that. Okay, so a very fair, okay, someone said it. Who is that? One of the course directors? No. No. Now I know they are the course directors. It's 2. Okay. So some of you actually believe that they are different. This is a large series, both for patients who underwent radiofrequency ablation as well as SBRT. So you can see that caudate is actually very, very low incidence of metastasis. And some of this has to do with the vascularity and how the blood supply flows through liver. And you can see that segment 2, 3, and 4 metastases are less. And this may also be an indirect reflection of the volume of liver, right, to have metastasis. But far majority of metastases are on the right side, 5, 6, 7, 8. And what is the limit of number of metastases that you treat with SBRT? Up to 5. Okay. We see 2 brave people here again who have no limit, 4. Okay, so it's really nice to see that up to 33 people in this audience are actually doing liver SBRT, even more than that actively. So let's come to patient selection. So some of you have already said that you could take patients up to 1 to 5 metastatic lesion, but then there are patients who have more metastases, like with breast and colorectal cancer, and they would go through multiple lines of systemic treatment, and then they are left with 1 or 2 metastases and would come to us, and those are also the patients one would treat. And patients in their natural history, especially when systemic therapies are very effective, they will keep on coming with 1 or the other liver metastasis or lung metastasis. So they can also come once you've treated liver metastasis in one lobe, they come with another lobe. So when we are selecting patients with liver metastasis, the broad principles are that you select up to, 3. If you're brave, you can go up to 5. But then there are people who are more experienced and they would believe in the principles of regeneration, and they would say that till we can spare 700 cc of normal liver, it's okay to go ahead. So any of these rules are okay and depend on your clinical practice and experience. The key is that when you're doing metastasis-directed treatment, it's very important to be 0.5 to 1 cm away from luminal GI mucosa. And this I say because for rib, yesterday we had a very different discussion, because rib sequelae, most of the times they are not lethal. Whereas if you have GI sequelae, upper GI bleed is very, very difficult to manage, and if you end up with an upper GI bleed, patient will have to undergo a Whipple surgery to take care of that. So we always take care that lesions are slightly away from luminal GI mucosa. And of course, in modern world, you would also run a checklist for systemic therapies, because patients who come after multiple lines of chemotherapy, they have something known as sinusoidal congestion in the liver parenchyma. So same doses and same constraints may not apply to them. So that is a consideration that you may have to consider. So next question for all of you, that apart from number of metastases, are there additional factors that determine liver SBRT patient selection or outcomes? And here you can choose multiple options. What do you think will impact patient outcome? Volume, timing, histology. Okay, that's interesting. You know, it's a typical radonc belief that dose and volume are the most important parameters. Is everyone done? It's still changing. But predominant is dose, volume, and timing in reference to systemic chemotherapy. So I don't put here individual studies because all of you are well versed with evidence. So what I did was I created a plot of all the studies that are available in literature. And in blue line is the biologically equivalent dose, and orange line is 1 year local control. And when you look into this graph, you realize that once you hit a BED of more than 100, the local control, 1 year local control that you can achieve is 92 to 96%. So it's really, really important to stay here. And what you also learn from this plot is that there's no need to be over aggressive and go to BED 200 plus. Right now, seems to be a limited dose response relationship above 100 BED, and once you hit 100, 120 BED, respecting OARs could be a more sensible thing to do. But all this data is based on 1 year local control, and if we look into further, I will speak about further in further slides, that 1 year local control, 2 year local control, and 3 year local control look very different at these doses, but we don't have sufficient information of 3 year outcomes. Maybe a higher dose is beneficial, but till now, if you have to remember a ballpark figure for yourself, it should be 100 to 120 BED that you should be targeting. And many of you did not select that if primary tumor determines outcome. Here you can see that local control is best with breast cancer, and it could actually get worse when it comes to lung and colorectal metastasis. And this may be related to the inherent radiosensitivity or the mutation types that these tumors may have. And what I was speaking just, on dose response relationship, this is a very nice radiobiology paper written by a single author, and nowadays we see very rare papers which are written by single authors, and he's put all his experience or her experience together, and you see that 1 year TCP plots look very good at 90% after a certain dose. 2 year TCP starts to fall, which is in blue, and when you see at 3 year TCP, which is red here, is even lower. So we don't have sufficient information, and this information will become less and less because many of these patients also receive systemic therapies. So I don't think we'll become more wiser in time to come. And if you have to select a dose based on what I have said, if you're treating a colorectal metastasis, consider a higher dose, and the best data is at 17 gray in 3 fractions or equivalent BED. But if you're treating non-colorectal metastasis, you could possibly choose a slightly lower dose. And this radiobiology parameters also tell us that the alpha beta of metastasis is very different than primary tumor. And here alpha beta is 16 to 28 gray of colorectal metastasis. So much needs to be done to understand this aspect better of dose response. There is also an impact of cancer genotype and liver SBRT. And in this slide, the take-home message is that if there is colorectal metastasis and if patient has KRAS or TP53 mutation, the local failure is going to be high. So probably these are the patients where you could select a higher dose of BD as compared to other patients. And then this is very, very interesting. I had personally never thought it in that way, and this paper is very recent that came in 2024, that there could possibly an impact of segment location on tumor control. And it seems very logical, because if you are on medial side and near the GI structures, you would possibly use lower dose, whereas if you're more peripheral, you would like to use a higher dose. And here, for the first time, someone in a match pair analysis has very nicely shown that for far majority of segments, there is no difference between radiofrequency ablation and SBRT, but when you come to segment 7 and 8, SBRT outperforms RFA. And the reason for that is that these segments are very close to the portal triad, vessels, rib, where normally RFA would not be that efficient. So when you're sitting in multidisciplinary clinics, even if it's a small lesion in segment 7 and 8, preferentially SBRT could be chosen for these patients. And many of you selected tumor volume, and there is a clear impact of tumor volume. The cutoff is 40 cc, but we are treating smaller and smaller metastases because of increase in imaging. So I don't know how relevant it is to our practice, but this data comes from the large German DEGRO study, which has put 623 metastases. So this data seems to be very robust. And then again, this is also a no-brainer that late recurrences have better outcomes than early recurrences when treating with liver metastasis. And impact of systemic chemotherapy, I think this is very, very important, and some of you have chosen this, that there is an impact on timing of systemic chemotherapy. So far, majority of the series show that the outcomes are much better when SBRT is given upfront, not after systemic therapy. One may think that, okay, we give systemic therapy, and if patient does well and later on comes back, we treat that oligometastasis. But no, in this cohort, outcomes are poor, and the reason is, as in other sites, that there is possibly selection of chemo-resistant clones. There is maybe you draw smaller volumes when patients come after chemotherapy, but it's very clear that if you have to use SBRT, it has to be upfront. And here you also see a difference between breast and colorectal cancers. When there is no prior chemotherapy, breast yet does better, and this trend maintains, but the difference widens a bit. Of course, it is very difficult to interpret these graphs in isolation, but if you can go first, so it's SBRT first approach should always be there. And institutions matter a lot, and institutions that routinely do SBRT have much better outcomes, and obviously because of increasing experience. And I refrain from putting too many clinical outcome series. All of us know outcomes are excellent, but if you have to remember some ballpark figures of overall local control, and it's Dutch-Belgian registry, and Ben had also mentioned about it yesterday. So Dutch-Belgian registry and the DEGRO registry are the two references for liver metastasis, which could be used to quote outcomes at the community level. So next question comes that, okay, you've decided based on these factors that I'm going to treat patient with treatment. How do you actually proceed with SBRT? So can I have a show of hands? I think that question is not here. How many people do fiducial placement for SBRT, and how many are using some other technique? Can I have a show of hands for fiducials? Actually, I see very few hands for fiducials. So what are the other techniques? You can speak out. What are the other techniques that are being used? I see only 2 hands for fiducials, 3. Okay. Does anyone want to speak out? What's the alternative that you use? Okay, we'll speak about it later. But if you have to do liver SBRT, I think having fiducials is crucial for matching unless and until you have MR-Linac and you can see the lesion itself. So fiducials generally should be placed at 3 edges, and these are gold markers, but in our country there's a problem with finances. Patients cannot buy as many gold markers, so we are very restrictive in the number of fiducials that we put, and generally we try to put 1 fiducial at the minimum, and if patient can afford more, then more fiducials, but 3 is actually a dream for most of the patients with the cost of gold seats. Typically, these seeds are 5 millimeter long, 0.75 to 1 millimeter, and once fiducials are placed under ultrasound guidance, you must do an immediate check scan to know their location, because fiducial migration is also very well known between putting the fiducials and then patient coming for treatment after CT simulation. And fiducials, though, are very good. They do impact delineation, and you can see here how much of streak artifact a fiducial can give. Some CTs, now modern CTs, do have metal artifact reduction algorithms, and they should be considered, but far majority of publications show that fiducials actually not only make the identification of lesion difficult, but even follow-up scan interpretation difficult. So that is something to consider while using fiducials. And this is a study which shows fiducials versus liver contour based matching. It does not show any difference in the quality of match, but what it does show is that fiducials should be preferred in their ability, because on non-contrast CT, the localization is much better if you have fiducials. We've already had this session during Shantam's lecture and also yesterday in lung, that what are the strategies for planning liver SBRT. 4D CT is preferred a lot in lung, and we almost try to avoid it in liver, because liver SBRT you use for patients who have either multiple metastases or they will develop multiple metastases, or it's in patients with HCC, so you want to save as much of normal liver parenchyma if possible. So most of the institutions trend towards motion restrictive strategies, and we've spoken about it, and we've seen in breast session, so I wouldn't spend too much of time on these slides, but this is just an example to show to all of you that how ITV based approach can increase the amount of liver parenchyma that is irradiated, and this should categorically be avoided, especially if you're dealing with large metastases. I will not go into patient training for SBRT, and I think in the morning it was, previous lecture it was discussed, but most of the patients should be trained adequately, either with a spirometer and a dummy session, not like this, but they should be actually made familiar with these, we use in our system these goggles where patients can see the respiratory feedback, because if you directly use on the patient on machine, patient will be hesitant to adapt that, and there will be some displacements with patient adjusting to the same. And enough has been discussed about these two techniques, and I will just take you through the DIBH method that we use in our institution through a slide. So what we do for imaging and treatment planning is we do everything in these deep inspiratory breath hold. There are people who like to do in deep expiratory breath hold. It's a matter of choice, and either of the techniques could be used. And if you have to prepare for DIBH, even though for metastasis, only arterial phase is good enough, still we encourage that all phases are required, and I'll come to it later on to show you why all phases are important. So IV contrast, if you have to give, it is 1.5 ml per kg body weight, and the rate is 2.5 to 3 milliliter per second. And triphasic scan should be acquired in breath hold. It has to be minimum thickness. You cannot have a 5 or 6 millimeter scan for liver SBRT. And we try to acquire right from carina to 5 to 6 centimeters below the liver, so that organ at risks are accounted very properly. And it all depends in which phase you are wanting to do delineation. For liver SBRT metastasis, it will be arterial phase. So when you are taking DIBH, it is very important that you link the breath waveform to the arterial phase, because if you don't link this, execution of treatment will be difficult. And generally, automated injectors are recommended. You cannot push contrast on your own and then run out and expect to have a triphasic CT, because by the time you are out, 2 phases will be gone. So all this has to be done from the outside console, and arterial phase is typically at 20 to 30 seconds, which shows hypervascularity. Venous phase, more important for HCCs, but I'll come to its utility in metastasis. It's acquired at 45 to 60 seconds, and delayed phase at more than 180 seconds. So this is an example of an arterial phase acquisition. look at this iota, it should look as if equal to bone when you need to have imaging for liver metastasis. And in this patient, you can see even in arterial phase, the metastases are not very clear and you're struggling to see them. And in such patients, other phases can be important. So regardless of the diagnosis, we try to acquire venous as well as portal phase. I'm told that this video is not working, so I will escape this video for how the acquisition is done, but we can play it later if any one of you wishes to see this. So once the scan is done in arterial phase and you have the images, first thing that you have to do is link the scan that you're going to delineate and treat it as primary, link the DIBH waveform to it, and then go ahead and contour GTV. And normally we don't give CTV unless and until the metastasis is of infiltrative type. And you take multiple imagings that are available to you into account. For example, if you have PET CT, please take into account, but don't try to see the size of the lesion through PET scan, because background liver parenchyma also has uptake. So always use a contrast enhanced CT scan to define the peripheral rim. And finally, you give CTV to PTV 5 millimeter margin. We don't do old style treatment of choosing a lower isodose for SBRT prescription, and we like to do simultaneous integrated boost. And this is very important, because if you want to dose escalate near OARs, because on one side is rib, other side is GI mucosa, sometimes we don't have liberty of, going for 4D CT. And if you've taken 4D CT, then you cannot do SIP because you don't know where your tumor is. So if you are planning multiple PTVs, then DIBH is the approach to be followed, and then you can have multiple PTV prescription while optimizing dose to GTV and reducing to the periphery. We've spoken about dose prescription earlier, about 100 BED, and these are the various dose fractionations that you can utilize. If you're very unsure about your setup and you're starting on early, I would recommend using 6 or 8 fractions, and then slowly go on to 3 fractions, which requires a very high quality of setup of patients. And organ at risk constraints, yesterday many of them have been discussed, and I think how I remember, it's very simple. Anything that's GI is 30 gray to 0.5 cc. You don't have to remember it. It's matched to 50 gray, because GI mucosa tolerates only 45 to 50 gray. So max dose, just remember 30 gray and you'll be right for all GI structures. Duodenum, you have to be careful because it doesn't move. So you can be slightly more stringent when it comes to duodenal dose. And when it comes to normal liver, you have to see if you are, so normal liver is liver minus GTV. If you have multiple GTVs, exclude them. And mean dose, if you're using 6 fractions, it has to be less than 18 gray. But if you're using 3 fractions, you can keep it 15 gray. And these dose constraints are very easily accessible. I will not spend too much of time into each of these dose constraints. And I want to mention about this very, very important model, because I have grown up looking at this graph and this model for all the liver SBRTs. This is from Princess Margaret, and this is actually a very neat iso-effective plot, and it has risk levels of toxicity. Blue line is 5% of RILD, 10%, and yellow is 20% of RILD. And this is developed both for HCC and metastasis, and it is on a parameter called as V effective. It's very hard to explain V effective because it has a mathematical corroborate by calculating each voxel dose. But broadly, what you can remember is that if your V effective is low, which means if you're irradiating small volume of liver, you can be brave and give much higher dose. But if your V effective is lower, that means you are treating a very large volume of liver, the prescription needs to be adapted. If you follow this plot, you are not going to see too much of liver decompensation in your clinical practice. And this is an example of V effective, how we used to calculate in our institution, that once your TPS has given the plan, you extract per voxel dose and then come to a V effective value. So you give a prescription when you start planning. For example, if I've given prescription of 54 in 6, but this V effective comes as 0.29 after calculating, then I'll go back and go back 1 dose level lower. So that is how you adapt V effective in clinical practice for liver SBRT. Coming to toxicity after liver SBRT, So toxicity of liver SBRT mostly is from HCC series, and you see here sharp increase in curves. This is not a reality for liver metastasis because these sharp increase comes from change in liver enzymes, and this is mostly in patients who are in background of hepatitis and hepatocellular cancer. Metastasis series is inverted red and green, and you can see that it's on the flat 0 line or under 4%. So for metastasis it is very safe. But yes, when it comes to GI toxicity, if you are not careful, you can create GI toxicity for patients, and that's something that one has to really avoid GI toxicity, because as a clinician, if you see one bleed, you would take 10 steps back for liver SBRT. And finally, how safe is liver SBRT? Previously, I've shown you these plots coming from 6 or 7 series. In 24, actually, we had this very good systematic review, which has pooled more than 3,000 patients and 33 studies, and they provide a range of complications, grade 3 and 4, after liver SBRT metastasis-directed treatment. And you can see in far majority, and I'll read out these numbers for you, a far majority of series have toxicity grade 3, 4 under 7%. There are isolated 1 or 2 series that show higher toxicity, but they are from 2010. So I can expect that the technology would not also be that advanced during that time. Coming to, one comment about protons, like can you use protons for liver SBRT, especially if patients come again and again. And this is actually a very good study because I showed you a risk-adapted dose prescription based on saving normal liver parenchyma. And what these plots show you is that on basis of V effective, if you were to choose your dose, it's based on liver irradiated. So protons can be very conformal in low dose spillage, and what they show in this plot is that if you could simulate with protons, they can help you to select one higher dose level, but none of the clinical studies have done it. This is all theoretical modeling, and only one group, and this is from UPenn, where they speak about proton SBRT, and this paper is full of challenges, that there's challenges with onboard imaging, motion management, beam scatter, and it's very difficult. And finally, the author says that imaging and radiation oncology core Phantom had only 38% pass rates. So I don't know of many people who are doing proton SBRT for liver. If any of the faculty is aware of, no, okay. So now coming to VMAT, Prakash will speak about VMAT later today, but I just wanted to speak about few things because we've spoken about DIBH, and there was a question from one of our colleagues who said that how do you actually breath hold? Because there's a difference in simulation. Simulation gets over in 20-30 seconds, whereas the treatment will go on for 5 minutes. Patients cannot breath hold for 5 minutes. So how do you do it? So here is where training becomes important and physics planning becomes important. So when we train patients, we ask them to practice at least consecutive breath holds for 40 seconds, right? And it's not easy, consecutive breath holds for 40 seconds. Most of the patients, when they reach 5th or 6th breath hold, they will drop their breath and they will not be able to hold more than 25 to 30 seconds. So in our earlier days, when I used to do VMAT planning, I always used to tell our physicists that once you have planned an arc, prospectively split the arc. Like you don't have to do a whole arc, split the arc after every 25 seconds so that the arc is timed to patient's breath hold time. So your beam on time or for an arc should not exceed 25 seconds, and you can split your arcs because what happens is your machine is racing at a certain speed, and if patient drops breath and system has to stop, it is like stopping a car from 100 km/h to 0. It has impact on machine, it has impact on patient. So you can prospectively split your arc into different arcs and do your treatment, but it's a choice. Some people are very comfortable using a different approach. Planning parameters, Prakash will cover, much better, so I'll skip this slide. And only one consideration is that if you're treating synchronous multiple metastasis, try to have a single isocenter if possible, especially if metastases are close, because dose submission is very challenging with multiple isocenters. And if lesions are more than 10 centimeter away, then you have no choice but to use different isocenters. But then it's a very difficult clinical call how to dose submit and evaluate OAR doses. at Tata, this is a concept which is not widely published, but we piloted this concept because we were treating hepatocellular cancers which were 10 centimeter, 12 and 15 centimeter, and often we would not be able to save sufficient liver, even if patient was child A, B. So what we started doing is we started investigating an approach of segmental sparing coming from surgical philosophy, because surgeons spare segments. They don't go by liver minus GTV. So we started delineating each and every individual segment to see what impact liver SBRT has on different segments, because we were seeing patients on follow-up, especially HCC, when they come for 4th follow-up or 5th follow-up, half of their liver was shrunken, other was hypertrophied, and some would actually undergo liver failure if you were very aggressive in treating those patients. So what we learned from this exercise is that we started mapping dose per segment for patients, and then we put all our patients of HCC to understand what should be a segmental dose if we have to follow surgical philosophy, because liver needs to regenerate. And what we learned from this small simulation exercise, which had not too many patients but multiple segments, is that if you can restrict dose of individual segment to less than 10 gray, when you follow up patients, it increases in segmental volume. If you are up to 10 gray, it will remain the same volume, but if any segment gets more than 10 gray, over follow-up, that liver segment will start deteriorating in this thing. So this is something to be kept in mind when you are doing multiple metastasis SBRT. And DIBH workflow has already been spoken about very nicely. So I will just skip this DIBH workflow and will just like to say that that's how we do it. But of course, there are other centers who would use different methods of doing liver SBRT. Now coming to additional considerations, because a lot of patients are getting immunotherapy, and these are soft things as a clinician that you may want to keep in mind. And that is that when we irradiate large volumes, there is immune suppression and circulating lymphocytes increase in the system. And this is actually a very neat study which compared different, VMAT doses and different triple F or beam energy to see which beam has different impact on circulating lymphocytes. And what was very clearly seen is that 10 triple F leads to less circulating lymphocytes. It was an in silico experiment, and you can see that small parameters that we often don't consider can actually create some differences, but this needs to be further investigated. This is pilot data. And we also know now from these simulation studies that higher dose fractions are more effective than lesser to get immune response. 8 gray into 3 fractions is superior than 6 in 5. So if you have to choose a biologically equivalent dose, choose less number of fractions. And CTLA4 pathway gets more activated at 6 to 10 gray. But if you're giving doses like 45 in 3, beyond 10 to 12 gray, there is a lot of vascular disruption, and non-vascularized sanctuary sites can develop, which can debilitate immune surveillance and response. So recommendation is actually to stay per fraction 8 to 9 gray, preferably around 8 to 10 gray for harnessing immune response. And then a lot of drugs are coming in pathway. I don't even know how to name all of them, but these are the classes of drugs: BRAF inhibitors, EGFR, VEGF, and many of you, especially who treat breast cancer and colorectal cancer, will have patients going through these prescription medications. And there are published recommendations, and you can go to this paper of what is the policy or recommendation. These are soft recommendation of how to suspend drugs, because most of the times SBRT is interdigitated, and how many days patients should be off these drugs. And you will get these slides so that you can refer to this publication. A word about evaluating post-treatment response. Most of the metastasis and medical oncologists before immunotherapy would use RECIST criteria that doesn't apply to liver SBRT. And there is a reason for that, because when you give high dose, depending on the dose that you give to the liver, there is a different pathological response. Zone 1 is absolutely in the center where you can see necrosis, and then there is a zone where you have more veno-occlusion. So when you're doing imaging, the contrast gets pooled there and it doesn't come out very easily. So you have to keep these changes in mind, especially when patients later on come with a second metastasis, not to misinterpret these post-SBRT changes as progression or as new site, and one has to be careful about it. And I have put here, just how response evolves. And in acute phase, 1 to 3 months, you see more of sinusoidal congestion. And if you are doing imaging, you will have hypo-enhancement in portovenous phase, which is seen, and I'll show you some examples. And as you move to chronic phase, this can be an evolving response. So please always discuss the imaging with someone who's experienced, because many people can actually refer it as, progression. And this is a very good example. And here you can see a wedge artifact, this bright hyperintensity. I hope all of you are able to appreciate this. This is related to SBRT dose, right? And then in venous phase, you can see that a totally different enhancement pattern is there, and the adjacent pattern has become more hypodense. So I overlaid the doses on patient, and you can see this corresponds to different isodoses. And we know through some of this data that when you give SBRT, then in 3 or 6 fractions, the 20 gray isodose line actually corresponds to hepatic dysfunction. So you have to be, as a clinician, mindful about these changes post liver SBRT. So this was more about primary SBRT. I'm going to ask a more provocative question to all of you, if you would consider re-irradiation of liver metastasis. I'm seeing the orange going up. You can select that if you wish. Oh my God. Prakash, you did not vote this, right? Oh my God. My popularity is just going, very high fold. Now this is for fun, right? Who's voting? I don't consider these votes now. Indranil, keep a picture. You can. No. Okay, so I think I have quite an equal distribution for yes, it is easy, no surgery or RFA, and the person asking the question is crazy. Okay, so let's, go into some data about re-liver SBRT. Of course, there is little data. And very recently, actually, because people are becoming more crazy, so there is data, actually, for the first time, there is definition about different classes of liver SBRT. And you can see that there is a proposal for class 1A, 1B, and 2. And 2 is when there is no overlap. So there can be various situations when you are doing liver SBRT. One is that there is overlap of just 2 gray. Then there is a 50% overlap, and then there is no overlap. So today we'll show you one crazy type 1B overlap with patient follow-up to see that this is actually a reality and not only in publications. And this publication only has put all patients. So you can see here in this publication that far majority of patients, even in this case, are 1A, 1B, that there was some amount of overlap between treated volumes when they approach. And first phase dose on an average is around 45 gray in 2 or in 3 fractions. And second time also people have used around 40 gray. It's not very easy to understand the fractionation from this pooled studies, but there are reasonably good outcomes. And what is very important is that in this study, which has 12-month follow-up, there is no grade 2 toxicity, which means you can get away very effectively after doing liver re-SBRT. And with this, I will come to end of this presentation, and I will open now a case capsule, which I have given as homework to all of you for contouring. How do we go back to this? Can you help me, please? Because this was in Mentimeter. Mika will need your help with the case capsule and this thing. So yesterday we sent homework about a lady. So while slides are going up, I'll tell you the story, and actually it's very interesting. She came to us in middle of COVID pandemic, and she had synchronous liver metastasis with primary cervical cancer. And no systemic chemotherapy in May 2020 was being administered in our hospital. So we were left with little choice. She did not receive any concurrent chemotherapy for cervix cancer. She did not receive any systemic therapy for liver metastasis. And we treated her with CTRT and brachytherapy to the pelvis, because that is the recommendation for GYN cancers, that you treat oligometastasis radically. And we treated the liver metastasis with 45-3. It was in segment 8. And then a year later, she came back again at a distance of 1.5 to 2 centimeter from that lesion, another new lesion, which was proven positive on fine needle aspiration cytology. And then again, this patient now refused chemotherapy when we sent her to medical oncology, and she said she didn't have money for RFA. RFA is more expensive in our institution. And we were almost forced to consider SBRT for her. And what is very important is that after first SBRT, this lesion was very close to chest. We violated dose constraints, and she developed rib pain. So it was a very complex situation for us, that she has toxicity from first SBRT, then she doesn't want chemotherapy, she doesn't want RFA, there is no other therapeutic option. So it was almost out of compulsion that I had to go again and treat her, which was in 2021. And now this lady, it's 24, she's metastasis free, there is no local relapse, it's 4 years, and never in her history has she received systemic chemotherapy. So what we are going to do now, I had given you, homework, and Mika, maybe we can directly, maybe just show lesions on, okay.
Sorry.
Okay, sorry. We'll let the case hold. Is there a way to switch to the case capsule?
This one?
Yeah, next, this thing. Okay. 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 So you can see this patient. This was the first time in 2020 that she had a small metastasis here, and this was very close to rib, and I have told you the clinical history, and we had to go ahead with SBRT. And then, just repeating the clinical history, she came with a second lesion here, and it looked very vague to us. Initially we were not convinced, but then radiologist suggested fine needle aspiration cytology. And you can see here, she not only had rib pain, she developed a lot of soft tissue features here also of previous chest toxicity. And we had to go and treat her again in 2021. And now we will go to contouring, because yesterday we gave homework to participants to contour this, and I'm very happy actually 16 people have returned homework. I could go to I will just load the image series. So we have 2 image series here. You can see that we have primary and secondary, and registration was important to us only when this patient came back the second time. So the direction of registration is that the secondary CT was considered the one on which we accumulated the dose, and later on Prakash will speak about this. So what we would do is, now we will go to, okay. It's not. Yeah, yeah. I think till CT primary is loading, we can go to secondary. And this is the same patient, where I have shown you some images. So this is the second one, right? And you've just seen the images. This is SBRT changes, or it's also a wedge artifact sometimes that can be created in patients due to also fat changes or fat necrosis that can happen. And when you come to lesions of this patient, can we switch on? Yeah. Okay. So now what we will do is, we will just open So there are a lot of changes that you're seeing here, and this can be very confusing. Like for example, I would not be surprised that if someone considers this as gross tumor volume and this as gross tumor volume, and then there is a third lesion which is here as gross tumor volume, but I was very pleasantly actually surprised looking at homework that people have done. So you have to be aware of these changes because radiology can also get confused if they have not seen enough SBRT patients. So Mika, can we open up GTV2 from master contour and
master contour?
Yeah, actually I noticed that there was some discrepancy in my instructions, so people have swapped. So we will open both for practice structures, we will open both GTV1 and 2 because people have contoured and we can change color to.
So yours is blue.
Yeah, yeah. Okay. So you can see here that there is quite an agreement, right? So I'm just going to go to the secondary lesion, which is this one, blue one. This is the master contour, and I'll just try to zoom if I can. Yeah. Yes. So this blue is the actual lesion, and you can see that there is almost a very, very good conformity for far majority of people. But then I also noticed that some people started chasing these post-SBRT changes that are there in the liver. And this is exactly what we were speaking, and you can see that these extensions can move in variety of places. This patient only had 1.5 into 1.8 centimeter lesion, and some of you, maybe because of my instructions on these slides, contoured also GTV1, but I'm not sure if you actually ended up contouring this wedge shape change that was there during liver SBRT from primary session. But overall, you can see that in reference to master contours, the GTV volumes, there is quite a heterogeneity. Like this particular lesion, there is good agreement for vast majority of patients, for people who have contoured. And then what you start chasing here are these post-SBRT dose-related changes, which are seen much more, as I've already shown you when we go here. And here, because of the streak artifact of also the fiducials, the contours are moving in a totally different direction. So my suggestion for such things is that when patients come with fiducials, there are two things to be seen. One is the PET images. Second is the pre-fiducial CT scan, because you will see the lesion very clearly there, and take some measurements, right, from the portal triad, take measurements from the rib. It's always not very reproducible, but it can guide you very well, because otherwise GTV volumes can be all over the place, and then you end up choosing a lower dose prescription. I will pause here for a moment and take questions, or maybe we should first have Prakash's session and then take questions. Prakash, would you like to come? So I have requested Prakash. Prakash had also sent homework for planning of these two liver SBRT lesions as 2 courses, and he will show you the results of the homework exercise.
Hello, good evening everyone. I am presenting here the liver SBRT homework evaluation. The patient with liver metastasis from cervical cancer, we forwarded 2 data sets. The one data set, that is liver SBRT done in May 2020, named as CTMP 2020 with planning target volume 45 gray in 3 fraction and PTV 42 gray in 3 fraction. And the second data set, that is liver SBRT done in 2021 with the data set name CTMP 2021 with the PTV 54 in 6 fraction and PTV 48 gray in 6 fraction. Both the data sets were sent to the medical physicist along with case capsule and the data Excel sheet to fill. This is the parameter asked to report for both cases. If you see the parameters are not that much. From last 2 days, we are listening the lectures about the plan evaluation and the various indices, but these indices are not included this planning sheet because so why to because to make it easy so that most of the maximum people should participate in this activity and send the planning. So we kept it simple. So I will show you the analysis of course 1 liver SBRT. The PTV 45 GTV, that is also called as GTV volume, it is about 12 cc. Then the another we did SIP planning here. The PTV 42 volume is about 59 cc. Here the main task is what, that the chest wall and uninvolved liver segment dose was the main concern. So with optimum target coverage and steep dose gradient, how we can achieve that, that is the main aim. And the rest of the targets we have to keep as low as possible, reasonable achievable ALARA dose. So these are the target contours. Already most of the oncologists now did that task also of contouring. So here the PTV 42 and 45 and PTV 42 with this is with the various OAR contours. So we received 5 homeworks. The last date was 28 November and all the homework plans were VMAT plans. The whatever reference plan that we treated this patient, that is also a VMAT plan. So this is the good comparison. But here what we observed, this is the data. There are so many parameters. So there are 2 slides. So in first slides you can see that the NR is not reported, means 2 institutes. The one institute, that center 3, they not reported a PTV 42 volume and PTV 42 volume of 100%. And they also reported very low dose, we will see in next slide. And whereas center 5, I don't know why they not reported V 100% for both PTV 45 and PTV 42. So we excluded that because as the OARs are low, but as we don't know what is the target dose, so for comparison it is very difficult. So we excluded that. So here the center 1, what we observe that now rest of the, if you see this almost all the constraints, target coverage and the OAR constraint, most of the people achieved other than the chest wall dose. If you see the chest wall doses and the chest wall Dmax, that is exceeding out of tolerance, means whatever tolerance we received, it is out of that because it is very nearby to the PTV 42 and some of the chest wall is inside the PTV volume also. But the center 3, I think they planned on PTV 45 only, or how I also like to know how they achieve such a low chest wall dose 1.9, and if you see 30 cc volume, they reported 11.3. So I would like to listen from them that how they planned. Other rest of the institutes, they are having higher chest wall and the Dmax dose and the 30 cc volume. So the analysis, the target dose in center 1, they reported lower target dose, but it is means it is more than 95%. It is not, they are not fulfilling that, it is not like that they are not fulfilling, but it is lower compared to the reference plan. And also they reported lower doses to the normal liver, mean dose 700 cc dose and the most of the OARs, but they reported higher total liver mean dose, stomach dose and the chest wall Dmax. The chest wall Dmax is about 116% of the prescribed dose. So here after the evaluation, the forum will be open for the discussion whether the oncologists are ready to accept such high percentage dose on the chest wall Dmax, that we will discuss afterwards. Then center 2 also the almost similar pattern they did. They also mentioned the chest wall Dmax about 110% of PD prescribed dose. As I mentioned, the center 3 not reported PTV 42 dose, reported very low dose to the chest wall, and the other OARs looks like they planned only on PTV 45. And in that also they have lower PTV 45 dose than the reference plan. So but still they are having higher mean dose of uninvolved liver segment. That is the observation. Then center 4 is also like center 1 and center 3, that they have lower PTV 42 dose but having higher PTV 45 dose, but here the chest wall Dmax also again 114% of the prescribed dose. This may be due to the bone. Most of the time physicists know that the bone, the bringing low dose to the bone, it is very difficult. So maybe they not optimized it or what, I don't know. So they received 114% of the prescribed dose, and also they reported higher mean dose of uninvolved liver segment. Then as center 5 not reported we 100% of target, so we don't how to evaluate this, but they their OR doses are the lower except normal liver dose and the 700 cc of the normal dose. They not focused on the liver at all, and they also not reported we 100% of the target. So my conclusion is that all plans including reference plans exceeded chest wall Dmax. The reference plan is also having, if you see the chest wall Dmax, it is about 105% in reference plan, whereas in other plan it is as I mentioned 110, 114 and 116 dose to the and all hallmark plans are the having lower chest wall 30 cc volume doses, higher mean dose of uninvolved liver segment and the stomach dose than the reference plan. Means they have lower chest wall doses 30 cc volume, but they are having higher mean dose of uninvolved liver segment. So it is that on which OAR you are giving priority. So here in these 3 plans, it is most of the they focused on the chest wall, and they the liver dose is higher in that. So OMOR plan from the center 1 to 4 have the chest wall Dmax greater than the 105% of prescribed dose, that is 116, 110 and 114 respectively. So once similarly I will show the course 2 evaluation also, then we will discuss. So whether this is how you accept the plan, whether a reference plan is good or the other center plan is good. So we will see the comment. So I will show you the some what we did in the reference plan. So almost as I told you, the all plans are VMAT plans. Our plan is also VMAT plan with the arc, partial arc starting from 180 degree to the 5 degree. Here we used 6x triple F beam. Then as Dr. Ganesh sir yesterday discussed that you should in SBRT or the minimum grid size should be lower to the 2 mm. So we selected here 0.2, the calculation resolution is 0.25, that is 2.5. It should not be more than 3 mm. So you can reduce it this also, and these are our clinical goals that we received PTV 42. The 100% of 42 is 96.91%. Then PTV 45 we received volume of 100, 98.55%, and the normal dose to the liver is for 700 cc it is 0.76 gray, and the D mean is 3.67 gray. So these are some screenshots of our reference plan. So you can see the conformability Even I not mention the indexes here, but you can show visually that the 45 gray dose volume and the 42 gray volume, it is confirmed to the target. Then this is the dose follow-up. For dose follow-up, I took this 33.75, which is and 22.5, which is 50% of the 45. And this is the low dose volume for 20 gray and 10 gray volumes. So, and these are the DVH for our course 1. So now,
Prakash, can I make a comment if you can just go to one slide before? So you can see here isodoses and the liver segment changes that I had shown you on follow-up. They closely follow these 19 to 20 gray isodose volumes. So these are things which produce imaging changes later on.
So similarly, now the course 2 assignment is relatively easy to the course 1. It have 2 volume, PTV 54 of about 8 cc volume and PTV 48 of 21 cc. As in the case capsule, it is mentioned that there was rib pain. It is mentioned by the patient that rib pain and the chest wall changes. So there is need to use the avoidance sector for that previously irradiated region. That is the main key while planning this course 2. So here also we received the plans from the same 5 institutes, and again these plans are the VMAT plans with partial arc 200 and about 200 to 220 degree arc. So here if you see the most of the, again the center 5 they not reported V 100%. So that case we not included, because as we don't know the target dose, whether they means they received a low dose or what is their plan, we not able to conclude. So we not evaluated that. We not get idea how they planned. So if they are here, so they can give the answer to that, why they not mentioned and how they did it differently if they did. Then here the main almost all the constraints, all the target coverage objectives and the OAR constraints are fulfilled by all the 5 institutes. Even they not mentioned the 100% volume, but they achieved all the OAR constraints. Similarly, rest of the institutes also with the reference plan also. So here what we observe that most of the see, you can see the reference plan is having higher dose chest wall Dmax, which is 31 gray, whereas other they are receiving about 24, 26 gray. Similarly, chest wall Dmax also the reference plant it is higher 16.4, whereas other is the lowest is mentioned is 14.9. But if you see here the mean dose of uninvolved liver segment, which is which is low in reference plan, about 2 gray, and where other institute it is not that much significantly, it is 2.14, but there is difference. And the second difference what I observe, that is the esophagus dose. If you see the 0.0 cc of esophagus, so reference plan is 1.35, whereas other reported more than 5, about 5 gray. So so that is the redistribution issue. So we received one OAR less, others received other OAR. So what
Prakash, can I just
yes.
make a comment here? If we go back to that slide, so when we see max, right, the readout can be higher, but location is also important.
Yes, yes.
In our plan, you are going to show that, right? So just for audience, it's 2 cc or it's max, but it's not located at the same space.
So here the center 1, 2 and 4 again they are having the same methodology to report and all. So maybe they communicated each other or what, I don't know. But they are having so here the comparable 1, 2, 4 they are having comparable target dose with respect to reference plan. having lower chest wall and chest wall 30 cc volume, but a higher esophagus and main dose of uninvolved liver segment. Again, center 3, they are having higher chest wall. This time they achieved both the target coverage, but they are having higher chest wall Dmax. It is very high to the others, means the mean dose of, if you see mean dose of uninvolved liver, they reported 4.4, whereas chest wall dose also higher, that is 32.69. So that is some bit center 3, I think it is a inferior plan with respect to other, no, but don't know about center 5, because then again they not reported 100% of the volume of the target. So the conclusion in course 2, that all homework plans fulfill the target objective and OAR constraint. Whether all homework plans, as I told you, that we have to consider the previously irradiated volume. So whether they considered it by using directional block or avoidance sector, it is not clear, because as the target is away from that portion, so almost having all are having equal, almost about same OAR doses. So in reference to the plan, in reference plan, more weightage is given to reduce the dose to the previously irradiated area by using avoidance sector, and also to reduce the mean dose of uninvolved liver segment. So here the course 2 plan, here again we use VMAT plan, but we use 3 arcs, and here we use 10 MV triple F beam, as it is far. In first case we used 6x triple F, because it is closer to the chest wall. So whereas this is far from the surface, so we use 10 triple F and 3 arc, as we used avoidance sector for this. So here you can see the 54 gray 54 gray dose volume and the 48 gray dose volume. As we used avoidance sector, you can see that the 48 gray is not that much conformal as with respect to the first whatever that conformability we received. Here, due to the avoidance sector, we are not able to achieve that conformability. So this is the dose. Here you can see that how we avoided the previously irradiated area. So this is the all isodose lines, that 54, 48, 20 and 10 gray dose. You can clearly make out that so low dose we avoided that sector, and this is the DVH for the plan. So thank you. Now this is open for the discussion. So if anyone want to justify their plan, who send the homework, they can also comment on this. And also,
do any of the participating institutes, the ones who submitted plans, want to comment on their techniques? Because I found that there isn't a lot of difference. It's probably slight difference in philosophy in planning. Yeah. Yes. So anybody wants to volunteer? Yes. Yes, please.
Sir, my question is if any difference between the dosimetric point of view, the 6FF and double F, 6FF, if you find any dosimetric.
No, there is no that much difference, but as here we are planning a DIBH, means for the motion gated treatment this is, and we want to treat means the beam time should be as low as possible. So we used higher dose beam, so we use 6 triple F rather than the double F.
And my question is, in VMAT case, how many arc you give in this plan?
No, Unfortunately, that part that is not the parameter in the Excel sheet. So no one reported that whether they use double F or triple F. But I think most of the participants are here. If they want to mention or comment, they can.
Thank you.
Thank you.
Sir, as you told in second plan, you use 10 triple F and 3 arc.
Huh.
So is it possible 6 triple F with 2 arc? As we got good coverage, and also you have seen.
No, as I mentioned that this target is far from the chest wall, means from the patient surface. And as we give the avoidance sector, and you need more degree of freedom. So we used 3 arcs with the different collimator position. So we get more degree of freedom to get the dose.
So collimation you used, right?
Huh?
Collimation you used.
Yes, yes.
So
Yes, we use different collimator. Even we use same arc, but the collimation is different. You can
for
see.
dose follow-up you used different collimation.
For the arcs,
Arcs.
for the arc, we use different collimation, means 30 degree, 330 degree, 85 degree, like that. So you will get the different segments, you will get more degree of freedoms.
Okay. Okay.
Sorry if I missed anything, but what was the algorithm did you use for your reference plan?
This is the, in 2020 we have the algorithm is Accurus only, Accurus XB. The version was 13.5 and now we are having 15.5.
So you used Accurus only?
Yes. So most of the whatever you mentioned yesterday in the treatment planning, so all things are yesterday in T. Ganesh sir lecture, they provided what are the minimum things you have to see for the treatment planning. So most of the things are we included in our planning already in 2020. Yes. Only the grid size, it should be less than 2 mm or about 2 mm. But here, as you mentioned, it should not be more than 3 mm. So we took 0.25 in 2020.
I wanted to invite your comments on chest wall, just because people were asking yesterday also, and we thought we'll speak more about it. Like, what would have been your philosophy given location? And because here we became 42 gray instead of 32, 32. So
I think we talked yesterday a little bit about the fact that depending on where the target is, we would always generally prioritize the target and then accept the dose that's required for the target. But because we have a bit more information about the chest wall constraint, we can then counsel the patient a bit more accurately about what we think the risk is for a given location as to what to expect. So 5% risk of chest wall pain, or 1% risk of more serious chest wall toxicity at 3 years or 5 years. But I think we would always prioritize the target. I think in the same way that you have specified that you would generally try to make sure the coverage for the target is good during the planning. Is that accurate to what you would do? I mean,
because otherwise, patient's toxicity sometimes can create a lot of fear to go again. And now this patient actually has no rib pain. She has soft tissue changes which are seen on imaging, but she's clinically asymptomatic. So I think over a period of time, I think tomorrow also I'll try to cover in my lecture that side effects evolve and they go. And I think as a clinician, we could have gone horribly wrong also. But what Prakash has shown, what we did was that in that conformance avoidance sector, and we switched on even before coming here all isodoses to see. So that particular part of chest wall received less than 2 gray. So it was snugly this soft tissue density that was post SBRT. We tried to make sure that it gets no more than 2 gray in second course of radiotherapy. So that was the only consideration.
I would like to ask the center 3 that who reported very less dose to the rib. So how they achieved that, or what is their planning strategy behind that? If they want to comment, they can comment on that.
How do you know which one is center 3?
No, the who reported, they may know. That's why I'm asking.
I have a question because nowadays we're getting a lot of rectal cancer patients, and I mean, once in a while they do present with isolated liver mets. So what do? You go, you start with SBRT to liver, or go with TNT, and most of the cases the liver met they disappear. So how do you?
So I don't treat personally rectal cancer, but I can tell you in colorectal JC, because I have some past history of doing rectal cancer. So most of the colorectal cancers, the evidence is for surgery versus RFA. So very rarely actually colorectal metastases come to us, but when they come, if you give systemic chemotherapy, they will disappear. Then you will not even be able to put the fiducial. So if you see a metastasis, I think put a fiducial and treat it there and then, because later on it's going to appear again. So after first chemotherapy it will disappear, but then it will come back, you know, months or years later. So when you see it, treat it.
The role of SBRT in liver in a patient with, you know, active hepatitis B infection.
That's a separate topic, but let's consider it in the setting of liver metastasis. So active hepatitis we don't treat. Active hepatitis can only be either it's drug induced or it is virus induced. If it is virus induced, we put them into 14 days of entecavir, let the enzyme settle and come back to within normal range, and that is the time when we could consider to go ahead with SBRT. Other is drug-induced hepatitis, because many of these drugs can also lead to what they call as blue liver, many of the colorectal drugs, because that is out of sinusoidal congestion. So if patient has received multiple lines of chemotherapy and has actually hepatitis that is not obvious but seen somewhere in enzymes, I would use dose constraints as I use for child B category patients. So there are different dose constraints for normal liver for child B category. And if they have hepatitis, another thing to consider is that if they have segment 5, 6, 2, 3 lesion, which is the medial lesion, some of these patients, depending on the stage of their hepatitis, can also have esophageal varices. So even minor doses sometimes can aggravate bleed. So in such patients, I always get an endoscopy done prior just to make sure there are no varices. And if there are varices, get their banding done, because you don't want to see that your doses are okay and yet patient lands up with an upper GI bleed. When you had a comment?
Yeah, sorry. What I regularly see in our clinic is that, for example, if the tumor is close to the stomach, let's say the stomach constraint is very hard, so it's really respected. So you underdose, be underdose the tumor. Is that also what you're doing?
Yes, for GI structures we underdose. So that's the reason SBRT becomes less effective in these medial segments, because getting to 100 gray can be very challenging. So there I'll clearly prioritize OAR, because patient can die within, you know, 1 week if they have a massive GI bleed and you're not able to handle that. So,
okay.
Yes.
So I want to ask that what DMAX our consultant are happy to accept, because here in almost 3 plants we see that it is more than 110%. So if anyone want to comment on that.
Maybe some of the other colleagues who've sent plans should speak. The clinical colleagues, yes, please.
Thank you for that wonderful session. I just wanted to clarify something. We're actually from Center 5.
Yes.
And my understanding is that only yesterday did we clearly understand that the priority should be given for the tumor completely. What we did is we excluded the part near the chest wall, accepting that it was a bad adverse event that the patient had experienced. So we kind of accepted an underdosage to that area. That's what happened. But so we were able to achieve the constraints well enough, as you have seen in the second course. And in that area, adjacent to the chest wall, we had only about like 85% coverage as compared to the rest. So just wanted to clarify that.
Okay, okay. Because it was a good plan, but as you not mentioned the 100%, so we are not able to conclude that. So maybe you achieved 42, PTV 42 more than 95%, but PTV 42, I think she's saying 85%. So
So, can you hear me? So, as a normal VMAT plan, what we do if tumor is in deep seated, so we increase the beam angulation, means number of arc,
yes.
either, or we increase the energy. So, you used in that plan 3 arc plus energy you have increased. So,
Yes.
number of arc you increase because of conformity, you got better conformity. For which purpose we used?
Yes, for the conformability only, because as we are using avoidance sector, it is very difficult to get the conformability with 2 arc. So by increasing the arc and the giving collimation angle, we will get the degree of freedom to achieve that conformability.
I think for number of arcs, I also have a comment, and I think whenever we ask physics to make plans more conformal, they use more arcs. But there's a trade-off. High dose gets better, but low dose spillage increases. And as we are getting into this zone of also having a lot of systemic therapies, we should be careful and measure what less versus more number of arcs give. And second thing is that we are from a public sector where beam on time is very important to us, and I'm sure in private also beam on time is very important. So when you have more arcs, like for example even for GY and radical treatment, I see many of the centers in Europe, they will plan with 4 arcs, whereas we plan 2 arcs, and the simple mathematics for us is that 5 minutes less on machine, at the end of 40 patients you have 200 minutes saved and you treat extra patients. So that is another reason, which is a more practical one, when we use less arcs, which has got nothing to do with dosimetry.
Yeah, so I asked this question. Thank you.
Okay.
Any comments from anybody else? Any questions, comments?
So, it's not related to the planning per se, but more about imaging. So, when you got a patient who has a renal condition and you're not able to do a contrast scan, and you may need to use the PET information, but of course the PET itself carries motion artifacts. So, how do you integrate that into your planning delineation?
So here we will use this contrast MRI. Most of the MRI contrasts are more renal safe, and they are actually, you bring in a very good question. For some of the hepatic primary conditions, there are a set of contrasts which are different, and they actually pick up liver parenchyma, lesions, as well as injuries much better. So there is a space to use MR contrast, and then you can combine with your non-contrast CT for delineation if patient has renal conditions.
When you're actually setting the patient up for treatment, and you're not using fiducials, so how do you kind of ensure you're hitting the right place? Because how are you matching? I mean, what's the image matching criteria? Is it matching the liver to the liver? Or are you trying to match the lesion? Is it possible to see that? Oh, you are using fiducials, but if not, whoever isn't, that's a question for whichever center isn't using fiducials.
Many centers did not raise up their hands when I asked fiducials questions. I think fiducials are very important of one way or the other. In HCC patients, many times they have TACE iodine contrast, so we use that for matching. Whereas liver metastasis patient, I think it's extremely important, even if you can have one marker, and if patient sometimes has less money and cannot afford a gold marker, we ask our intervention radiology colleagues to put this RFA coil. It throws a lot of artifacts, but it is cheaper than gold seeds. This is one of the requests that we do when patients don't have money for gold seeds. And I think other centers should also say what they use, because many people are doing SBRT. So liver surface matching we are not using because you lose precision, and then on cone beam you don't see anything. But if your lesion is close to IVC or your lesion is close to POTA, they can be relative, but then there is a total loss of accuracy in doing things. Does any other center want to comment? Because we did not see raise of hands on fiducials.
Very nice and interactive session indeed. Now we request Dr. Pritanjali Singh ma'am to felicitate Dr. Supriya Chopra ma'am.
Oh yeah, I just wanted to say that we don't use fiducials for our CBCT guided livers or our MR guided livers. The CBCT ones are a little bit more tricky, so we will use surrogates, so internal liver anatomy surrogates. We also have the 4D CBCT that we will kind of look at the motion of, but it is really tricky with the image quality. Yeah, it's a tricky one. It's a trade-off of image quality with the artifact from a fiducial versus lack of visualization, and I think it just has to be a departmental decision on what they're comfortable with, I guess. But yeah, that's what we would do.
Seen one center using IV contrast at the time of CBCT for lesions to light up, but then you give contrast 5 times if it's 5 fraction.
Yeah, I agree. Even at our center, we do not use fiducials. It is the liver anatomy and some of the surrogates that we match. And occasionally we have had cases of liver mets where we are not able to identify, and in those cases we have had to omit giving SBRT. I agreed to that. But for the HCCs, vast majority of HCCs, I don't think so. We have had problems without using a fiducial. That's number one. The second thing was regarding the motion management. I mean, what's your take on using abdominal compression as a motion management strategy? And whenever we are doing that, we are also doing a 4D CT to look into the residual motion. So what's your take on that?
I think that is good to do 4D CT even with abdominal compression. We used to do we used to have body frame in year 2000 and 2001. And then I think overall people got very worked up with the big body frame that used to be there. I think there was nothing else. It used to be accurate, external fiducial, then compression, and then 4D CT. It is just your way, but personally, I use DIBH because you can choose a higher dose level, because the moment you get into motion, you will be forced to choose a lower dose level for prescription if normal liver or OARs are a concern. It's about choosing higher BED.
Thank you.
Prakash, before you just one last question for you, Supriya, is regarding the timing of the imaging for response assessment, because I was just reading that it can even be 6 months, but we don't tend to wait that long.
Generally, patients metastasis, they'll get imaged at 3 months most of the times, and there's a difference between post HCC imaging and liver SBRT imaging. For metastasis, you would image, especially if you're planning to give further systemic chemotherapy to patient. If there is no line of treatment, then you can image after some time. And imaging should also be directed your ability to go in again. So for patients where I can go in again with second, third, fourth course of treatment, I would image them more aggressively as compared to patients where I think it's very patient guided when you get into metastasis zone.
Ma'am, regarding imaging, do you do anything to check, fibrosis of the liver, fibroscanner or anything, if you are doing re-RT or like this?
So there are a couple of PET agents and fibrosis imaging and even ultrasound guided fibrosis imaging that are there, but clinical practice of re-RT at present is not very high. So when it will come, then like HCC, one will have to use, there are a lot of other functional tests which I have not covered today, which are like ICG test, which intervention radiology uses, fibrosis scan, ALB ratio. There are a couple of other parameters because liver mets is easy. So, but yes, if we will get into treating larger metastases after multiple lines of chemotherapy, then I think looking more objectively into liver function is important.
Scan during follow-up, do you advise?
Doing fibrosis scan if patients' liver function tests are okay, because I think we also have to be humble that far majority of these patients don't have survival beyond 3 years. Whatever line of chemotherapies you use, most of them are very rare. This is a rare occurrence, what I have shown you. You of course show always the best cases, but most of these patients would go and till now I have not been using, but I'm not denying that in future there may be space for that, we don't know.
My question related to SBRT in patient position immobilization, because we are observed that the many of cases in Tata Memorial Hospital and plenty of number of immobilization used. So what is your suggestion, which is the best immobilizer, right, either than the orbit or the backlog or other body frame? And what is the best tips for the, you give your experience for the.
So previously I used to use both backlog and Orfit. I used to use an Orfit. Actually what you see is not an immobilization Orfit. Before we had goggles, Orfit was used basically for feedback of patients. We used to ask patients to take a deep inspiration, and you used to make Orfit in deep inspiration. So it was for patient guidance, not for fixation, that when they go inside the machine, when they breathe in, they should touch the Orfit. And later on we realized that sometimes patient breathe so deeply that they lift up the Orfit. So in our initial practice we used to use both backlog, and Orfit was more like a patient guidance rather than immobilization. But now we have given away, we just use that variant box basically for 4D-CT wave monitoring, and they get these biofeedback goggles. And I think advanced variant systems, we don't have the latest variant machine, we don't have Ethos platform. So this goggle that is there, it's not provided by Variant, it's a third-party system that is integrated both with the CT simulator and with Variant TPS through, it is in-house built.
And last question, what is give the best tips for the radiation therapist when you're doing like SBRT cases?
I will tell you what, one of the therapists told me as the best tip. Once for a 2 millimeter deviation, I said, okay, treat it, we have 5 mm margin. And the therapist told me, if you will say okay to 2, next time I'll say okay to 3. So the best tip is be strict with us.
Okay. Thank you, ma'am.
Thank you. Thank you. So if there are no further questions, we will conclude for the day. Thank you very much.
Requesting Pritanjali ma'am and Supriya ma'am to please join us on stage. Priya ma'am.
This is so formal, if you can't please my ex-roommate, so it's very...
So we're closing for today, but everybody's invited to the gala dinner at Royal Bihar, Swarn Mahal, first floor, 7 p.m. onwards. Looking forward to meet you all there.